Hello, my name is Alex Peloso. I'm a neurologist from Canada, and I will be uh, doing the recording for these slides on meningitis. These slides were previously prepared by Dr. Chamba from the neurology department here at UTH. This slide just shows you a map of the incidence of meningitis across the world. As you can see, some of the highest rates are in various countries throughout sub-Saharan Africa. As a result, you are very likely to encounter meningitis throughout your medical training as well as your medical career, so it's an important topic to be aware about. We'll start with some basics about meningitis. So first of all, broad definition is that meningitis is a clinical syndrome characterized simply by inflammation of the meninges. And this can refer to two different sort of areas. One is called pachymeninges or pachymeningitis, which is specifically referencing the dura mater. And then the other form is the leptomeninges, which references involvement of the arachnoid matter or the pia mater. This slide just gives you a very simple overview of the layers of the meninges in the brain. So you notice the outermost layer is the bone of the skull, and then underneath that is, and quite closely adhered, is the dura mater. And then if we go to the other side, the pia mater is quite closely positioned next to the brain parenchyma, the tissue, and the arachnoid matter is named that because it's sort of like a spider web, like arachnoid, and forms kind of a web mesh in between the dura mater and the pia mater. And this slide again just highlights that the involvement of the pachymeninges is what we would term a pachymeningitis, and again, this is the dura mater. And then you get a leptomeningitis when you have involvement of the arachnoid matter or the pia mater. And these are both sort of underneath the umbrella term of meningitis. There are many possible different causes of meningitis. Of course, sort of most commonly known is the infectious causes, which can include bacterial meningitis, tuberculous meningitis, fungal, most common of which would be a cryptococcal meningitis, as well as various viral causes of meningitis. But in addition to infectious causes, there are also inflammatory causes such as sarcoidosis or chemical meningitis, which could be from ruptured dermoid cysts or iatrogenic, so from post-surgery, or sometimes certain medications. And also malignancy can cause a meningitis as well. So the most widely recognized or known type of meningitis is that of an acute bacterial meningitis. And this can cause both a lepto and a pachymeningitis. And the routes of infection or routes of spread can include hematogenous spread, so from a bacteremia. You can have direct extension, so perhaps from a sinus infection or an ear infection, as well as axonal transport, which just refers to any bacteria or any organism that is able to move along the axon itself. And then the most likely causative organisms actually vary a little bit based off of both age as well as immune status. And so I won't necessarily go through all of the possibilities for each group here, as you can reference these slides on your own. But I will say a common thing, so age 0 to 4 weeks can include like group B strep, and this can often be actually acquired in the birth canal, so during birth. And then listeria is another important one to consider in neonates and newborns. This next category looks like the age got cut off, but refers to about 4 weeks to 3 months of age. And then from 3 months to 18 years, Neisseria meningitis is also very common, in Haemophilus influenza and strep pneumonia. And 18 to 50 years is a similar grouping, although the likelihood changes slightly as you notice the difference in the order, so from most to least common amongst the top three. And then age above 50 years, you'll notice that listeria also comes back onto the list. So often you need to include ampicillin for listeria coverage in both the young and the old. And then, of course, immunocompromised state follows a similar pattern of kind of our really young and our really old are also in a sort of immunocompromised state. So anybody in the middle of their life who also has reason to be immunocompromised is susceptible to the similar organisms. And so when considering an acute bacterial meningitis, you need to consider in your history some of the clinical features, as well as the demographics, which kind of fits again back into the age groups we just reviewed, as well as immunocompromised state. And this is both from a diagnostic perspective as well as understanding how best to treat them if that is your ultimate diagnosis. And then clinical features on history include headache, fever, photophobia, and the symptoms are usually there for less than a week. This is sort of a quite acute presentation, typically only a few days. Once you have sort of a subacute or longer presentation, bacterial meningitis becomes less likely. And then, of course, in addition, you're going to do a physical exam looking for any fevers. Are they tachycardic? Any signs sort of pointing towards more of a septic picture as well. And then the classic signs of meningeal irritation, including neck stiffness, as well as Brudzinski and Koenig's sign. This is just a picture demonstrating a Koenig's sign and Brudzinski's sign, both of which the idea being to assess for irritation of the meninges by trying to stretch them and seeing what response that elicits. So with a Koenig's sign, you have the patient lying on their back, like pictured here, and then you bring the knee up to about 90 degrees, the hip up to 90 degrees of flexion, as well as the knee to 90 degrees of flexion, and then you slowly try to extend the knee. And a positive sign in this case is that either this action is very painful or irritating, or any significant resistance or inability to extend the knee, as that kind of fits with more of a rigidity in the meninges. Whereas Brudzinski's sign, again, they're lying supine, and then you slowly flex the neck passively, and a positive sign would be flexion of the hip and knee. And again, that is trying to compensate for that stretching of the meninges that you're doing at the neck by trying to sort of relieve that stretching by flexing the legs. This slide is just presenting the study that looked at the frequency and rates of presence of the classic symptoms that we typically associate with meningitis. So the symptoms considered were fever, headache, neck stiffness, and altered mental status. The study looked at 696 patients who had confirmed bacterial meningitis, 50% of which was strep pneumonia, 37% had Neisseria meningitis. And then of these patients, 44% had the triad of fever, neck stiffness, and headache, and 95% had 2 of the 4 classic symptoms. So this is important to consider that by no means do you need all symptoms in order to make the diagnosis of meningitis or to clinically consider the diagnosis and therefore consider treating it empirically, because it's, especially bacterial meningitis, is a very dangerous diagnosis to miss or delay treatment on. So this slide is somewhat of a tabular view of the data we just reviewed on the previous slide, and basically compared the presence of the symptoms listed there in those who ended up with a confirmed diagnosis of meningitis compared to those who had some other diagnosis. And as you probably expect or would think with common sense, is that the presence of more of these symptoms as listed here gave a higher likelihood that the ultimate diagnosis was meningitis. However, it's still important to consider because many of the symptoms listed, such as headache, fever, nausea, vomiting, and photophobia, can all be quite non-specific, and there are many different things that can present with this. So it's important to maintain that clinical suspicion as well as to sort of know the cardinal signs and apply that into your ultimate formulation of a differential diagnosis for your patient. Also of note is, of course, considering the demographics of the area in which you're practicing, as well as the other past medical history and demographics of the patient in front of you. So there's lots of things, as is true across anything clinical when trying to make a diagnosis, that you need to consider for any patient presenting with anything. So this just highlights that, yes, the more, these are some of the classic symptoms to be looking for, and the more you have, the more likely the diagnosis of meningitis. However, when we refer to Brudzinski's and Koenig's sign, another study was done, 297 adults with a suspected meningitis, that showed there was a sensitivity of 5% and a specificity of 95% for both Koenig's and Brudzinski's signs. So this means that these tests are very bad at ruling a meningitis out. So their absence does not give you much confidence in saying that the patient in front of you does not have meningitis. However, a high specificity means that this is really helpful for raising your suspicion for meningitis, because if it is present, then that is highly, highly suggestive of a meningitis. It's also important to note that the sensitivity of the meningeal signs, and sensitivity meaning their reaction, the severity of the signs, are not proportionate to the disease severity. So somebody could have a fairly dramatic Brudzinski's or Koenig's sign that does not correlate to necessarily a more severe meningitis. However, as most things in medicine, it's important to consider that children often have a different clinical presentation and cannot just be referenced as small adults. Therefore, for a suspected acute meningitis in children, they may present with some very nonspecific signs, such as a bulging fontanelle, lethargy, irritability. And in this case, Brudzinski's sign is not very specific. And remember, Brudzinski's is one where you flex their neck and are looking for the reciprocal flexion in the legs. And so when it comes to children, nuchal rigidity, so again, neck rigidity, and Koenig's sign are superior to Brudzinski's in testing for suspected acute meningitis in children. You have a patient who you suspect has an acute bacterial meningitis. The typical workup that you should be considering is a full blood count and a differential, a chest x-ray, because remember, strep pneumonia is one of the more common causes, and so you may have hematogenous spread from a pneumonia. A blood culture, again, for looking for hematogenous spread and trying to identify your organism. CT and or an MRI, or possibly both, depending on the clinical situation. And then, of course, CSF studies with a lumbar puncture, primarily looking for your cell count, protein, glucose, and then culture, because it's really helpful to understand which organism you're dealing with. Regarding the sort of age-old question of doing a head CT prior to a lumbar puncture, there was a study done on 235 patients with a suspected meningitis, all who underwent a head CT. So 56 of these patients did have abnormal imaging, which could just be in reference to anything, and then 11 of them had mass effect, because the concern around just doing a lumbar puncture right away before having head CT imaging is this potential risk for herniation due to mass effect, that then you are releasing some of that pressure from their lumbar spine, and the concern for a downward herniation of the brain. And so there are certain things that are good predictors of an abnormal CT in these cases, as well as other clinical scenarios. One being an immunocompromised state, any history of CNS disease, any new onset seizures, any focal neurologic deficits, an altered level of consciousness, including even multi-step commands, and then, of course, papilledema, which is a classic sign of increased intracranial pressure, with these sort of clinical correlatives often being blurry vision. This is a CT scan of a particularly severe case of bacterial meningitis. The CT scan in this condition is actually often normal, or in up to about 50% of cases. However, you can see some mild signs of things like sulcal effacement, and this slide is up to show you that a severe bacterial meningitis can actually be a cause of what's called a pseudo-subarachnoid hemorrhage, because it can look like a subarachnoid hemorrhage. And so some of the notable things that we see in this slice of the scan is that there's some hyperdensity in the tentorium, which is the part that might be most suspicious for subarachnoid hemorrhage. There's also just obliteration of the basal cistern. So if you look around the brainstem there is no space. It's hard to distinguish one part, the brainstem, from the surrounding parenchyma in the temporal lobes and the cerebellum. So there's severely increased intracranial pressure. And then in addition, there's just sort of a more homogeneous appearance to the parenchyma that's visualized here. In other words, there's a bit of loss of the gray-white differentiation, as it is, the parenchyma is more uniform in color. So this would be a particularly severe case of bacterial meningitis, but it's important to consider sort of the range of findings that can be seen on a CT scan in this condition. So when considering your lumbar puncture, there are a couple of contraindications that you need to evaluate for. One being an abscess in the needle entry site, and this is, of course, to prevent any potential seeding of the CSF space with whatever infection may be occurring in that abscess. Significant midline shift on the CT scan. Similarly, a loss of cistern, so the basal, quadrigeminal, superior cerebellar cisterns, which is similar to what we saw in the previous CT. Posterior fossa mass, and then increased ICP, all kind of portend a potential risk of herniation with completion of a lumbar puncture, and then a coagulopathy. Another thing to consider is then there's an increased risk of bleeding associated with the procedure itself. This is a good table to compare some of the expected CSF findings in various types of meningitis, as well as compared to normal individuals. So some of the more notable things, I won't go through the entire table as you can refer to it yourselves, but opening pressure could be a little bit elevated with bacterial meningitis, but especially with a cryptococcal meningitis, this is sort of a key finding and common cause of morbidity related to cryptococcal meningitis is severely elevated opening pressure. And then, of course, you're going to do your cell count, which should be highest for bacterial meningitis. It is typically in the hundreds. And then, although it should be elevated pretty well across the board with a viral, fungal, and tuberculous meningitis. Your differential again, so bacterial meningitis, you're looking at a neutrophil predominant increased white cell count. With a viral meningitis, as well as fungal and tuberculous, actually you're starting to see much more lymphocyte predominant. Protein is often elevated, but can be normal in a viral and fungal meningitis as well. And then glucose is typically reduced in a bacterial meningitis as well as a tuberculous meningitis, and can be a bit more variable with viral and fungal meningitis. And then your gram stain is really mostly relevant for a bacterial meningitis. Just looking for any organisms, this is what's going to be picked up. And if you do a acid-fast bacilli smear, as is commonly done, that's where you're going to potentially pick up a tuberculous meningitis. And again, these are sort of the early stages that you get before the culture is completely done. Common across many medical conditions, there's always sort of a caveat or caution around immunocompromised patients, as they may not present in sort of the classic fashion or with the typical findings. And so you need to still maintain your clinical suspicion, even if some of your additional tests are not necessarily fully supporting, in this case, the picture of acute bacterial meningitis. So it can be difficult to distinguish bacterial from viral meningitis based off of their presenting profile. The bacterial meningitis etiologies vary with age, as we sort of went through in a few slides back, that table that showed the more common organisms. And then, of course, don't be fooled by CSF profiles in immunocompromised patients, as they can be a lot more variable and are not necessarily the classic pictures presented in the previous table. And sometimes this also revolves around either being falsely low because they aren't able to mount as robust of an immune response to the infection, or they could be higher than expected just from baseline underlying inflammation from what's causing their immunocompromised state. Most notably, this is seen with HIV. So now, also considering bacterial meningitis, we're going to look at a study done on syphilitic meningitis here in Zambia. It was a retrospective analysis of a cohort of adults with meningitis who presented to UTH between April of 2014 and December 2017. This study excluded those who had a pyogenic bacterial and cryptococcal meningitis. They then calculated the prevalence of syphilitic meningitis within this cohort and then looked at various sort of clinical, laboratory characteristics, demographics, and outcomes of this cohort. They did a study the study included 512 participants. 273 were male. The mean age was 37, and 84% of those in this cohort were living with HIV. So they found a prevalence of syphilitic meningitis of 5%, with a quite high mortality, with an in-hospital mortality of 17% and a one-year mortality of 53%. In terms of some of the clinical features, they noticed that participants with syphilitic meningitis had lower Glasgow Coma Scale scores than those with other forms of meningitis. And among the people living with HIV, those with syphilitic meningitis were less likely to have meningismus and had higher CSF white cell counts, which again goes back to needing to consider that those in an immunocompromised state may not present the way that you would expect them to, especially noting here that lack of meningismus. And so overall, the study concluded that the syphilitic meningitis was found in 5% of Zambian adults presenting with non-pyogenic bacterial meningitis and non-cryptococcal meningitis, and has a high one-year mortality. Therefore, a high degree of clinical suspicion for syphilitic meningitis is needed in all individuals in Zambia, especially in those living with HIV. We'll just do a bit of a review of sort of viral meningitis as a whole. So aseptic meningitis, also known as slow viral disease, became an area of interest at the beginning of the 1950s when it was considered a potential model for chronic nervous system diseases. And aseptic meningitis often just refers to when there is no causative agent found in a suspected meningitis case, and this could either be because it was simply not found on the testing that was done, or that it was caused by an agent that we are not able to test for, or where our tests are not particularly good at detecting certain agents. Enteroviruses are the most common causative agents of viral meningitis, with an estimated 75,000 new cases annually in the United States. And a study in the United Kingdom showed that the incidence of viral meningitis caused by enteroviruses and human pericovirus is double that of bacterial meningitis. So this is very, very common. The exact sequence of testing for these agents does depend on the patient's clinical condition and on any suggestive features in their history and physical examination. And you can do a PCR for enterovirus, HSV, the herpes simplex virus, CMV, cytomegalovirus, and VZV, varicella virus. When you do a lumbar puncture, especially in these settings where often it can be more difficult to get consent and there's a lot more stigma around them, it's really good to try to make the most of the single lumbar puncture. So consider saving CSF and asking the lab to save and hold CSF so that you can pursue the less common tests if the cause of meningitis is not found with your initial set of testing for the things that are most common. And so the thought of how one can get a viral meningitis is first you need to have viral entry in some way. So there's respiratory viruses that you can get from inhalation, such as mumps and certain kinds of enterovirus, as well as through an oral fecal route, also common with enterovirus. And then the idea being that you either get a pneumonia or a GI infection that leads to a viremia, where the virus particles are now in the blood, and then you get secondary infection. So in the lymphoid tissues, choroid plexus, and infection of the peripheral sensory neural pathways. And then from the secondary infection, you need the virus to now enter into the central nervous system. And sometimes this is from increased blood-brain barrier permeability due to sort of more systemic inflammation, and then also through activation of interleukins and immune cells that again cause this increased permeability. And then once in the central nervous system, of course, it can cause infection in the brain and the meninges, such as a meningitis. So treatment for meningitis is obviously ideal to be as organism specific as possible, and but of course cultures from a lumbar puncture take time to come back, and so that's when it's good to consider empirical therapy. But you need to make sure that your empirical therapy is appropriately covering sort of the most likely organisms to be found in your patient. And so this goes back to the table around the most common organisms sorted by age as well as by immune status. And so of note, the inclusion of ampicillin in empiric therapy is for your listeria coverage. So best to use in the young, the old, and the immunocompromised. And then otherwise including, so vancomycin and a third generation cephalosporin are good medications to provide coverage for many of the common causes throughout most of the age groups. And then of course, when you have immune suppression, it's good to consider potentially stronger antibiotics such as a carbapenem or fourth generation cephalosporin, and then the same ampicillin. And then post neurosurgery, again, you may want sort of heavier duty antibiotics for your empiric treatment. And then, of course, you would narrow down your antibiotics once the causative agent has hopefully been identified through lumbar puncture, culture, etc. And then you can have a more targeted therapy for the duration of their treatment. Another important consideration in the treatment of bacterial meningitis is the benefit of adjuvant steroid use. And so in looking at this, there was a study of 300 adults who had a suspected meningitis plus one of the following. So either cloudy CSF, a positive CSF gram stain, or a CSF white cell count greater than 1,000. And then this cohort was randomized to dexamethasone versus placebo that was given prior to or along with the first dose of antibiotics. These were the outcomes of this study recorded 8 weeks after admission, where culture results should be back. And so they were able to do also subgroup analysis based off of the causative organism. And they looked at two outcomes, I guess, an unfavorable outcome and death. And then they compared the dexamethasone group to the placebo group. And what you'll notice is that for both unfavorable outcome and death, there was a mortality benefit or benefit also in regards to unfavorable outcome across all patients with a p-value of 0.03 for unfavorable and 0.04 for death. However, this is sort of very close to not necessarily being statistically significant. And then what's interesting is when you dig further into the subgroup analysis that they did, you can see that all of that benefit across both outcomes is pretty much only derived from those with a strep pneumonia as the causative organism. So with the unfavorable outcome, you can see that strep pneumonia had a p-value of 0.006, and same with death, it had a p-value of 0.02, whereas the other organisms or categories listed here do not have a p-value that reaches significance. So most of that significance across all patients is actually derived from those with a strep pneumonia meningitis. And so what this has translated to is that there's benefit into using dexamethasone in those with a suspected bacterial meningitis, and then once your culture results are back, if the causative organism is not Streptococcus pneumonia, then you should discontinue the steroids. Whereas if it is a Streptococcus pneumonia, then you can continue, as there is shown benefit in this group. However, there is another sort of subgroup or cohort to consider, especially in the setting that you'll be working in here in Zambia, and that is the use of steroids in HIV positive patients with a meningitis. And this study that we have an excerpt from here shows that the use of corticosteroids in 230 patients, 90% of which were HIV positive, showed no added benefit in mortality. And this was a study done in Malawi. So that's another thing to consider is, again, all of your patients' characteristics in order to make the best decision for them. So both considering the causative organism as well as their past medical history or other conditions that may alter the benefit derived from the use of steroids. Despite the availability of good antimicrobials and things that can treat many of the causative organisms of meningitis, it still has quite a high mortality. Overall, it's about 20%, but it is a bit higher in those with a pneumococcal-based meningitis. Some of the risk factors for an unfavorable outcome in your patient could be advanced age, having a really low Glasgow Coma Scale score, any otitis or sinusitis, the absence of a rash, because this would be more suggestive of a neisseria, which tends to be more treatment responsive, whether they're tachycardic, have a positive blood culture, so basically they're septic, an elevated ESR, thrombocytopenia, and a low CSF white blood cell count. There are also many other complications of infectious meningitis to consider, other than just the high mortality. So seizures are quite common. The meninges are particularly prone to seizures, and therefore inflammation of the meninges is common in meningitis, makes them much more common to see seizures with these conditions. Of course, you can also have development of abscess, focal neurologic deficits. You can get subdural effusions, which could be empyemas. They could be actual bacteria-containing effusions. And then there are also other long-term complications that include hearing loss, cognitive impairment, hydrocephalus, learning disabilities, and epilepsy. And syndrome of inappropriate AH secretion is also common in meningitis, as it is in many CNS conditions. So it's important to make sure that you've checked your patient's sodium during their admission and keep an eye on that as a potential complication that can also increase mortality. And that takes us to the end of this recorded lecture on meningitis. I've left this slide up about questions because it would be good for you to prepare any questions that you may have, any points of uncertainty, anything you'd like more information on, and please bring these to the lecture and they can be discussed further, and as well as you'll get some more information in the class and have practice applying the knowledge you've gained from this recorded lecture. So thank you so much for your time, and we'll see you in class.